This conference will now be recorded.
Okay, good evening, everyone. I'm glad that most of you were able to work around getting logged in effectively. First thing I want to ask you is please mute immediately. There won't be any point along the evening except for the moderators who will need their microphones, so please mute. Also, I'm going to suggest that you turn off your video. The video actually will become a distraction to everybody who will be watching rather than paying attention to the presenter. Excuse me, so there's no real value for that. The other thing that we always remind you of is that anything that we talk about tonight, whether it's the doctor or any other participants, none of this is intended as recommendations or medical advice. We advise you to contact your doctor about anything you might hear that you'd like to discuss further. And questions, any questions you have, you can start to put them in the chat as we go along through the evening. At the break, before we do the Q&A, the moderators will sift through them, consolidate them, and then make the presentation to Dr. Matthew. And with that, I will turn it over to Howard Walensky.
Okay, I got to get prepared here, and I am having an issue, but 1 second. I mean, I should mention too, we're going to have a halftime visitor tonight, or at least that's the plan. Mike Scott is going to be coming in for a few minutes to talk about his program. At any rate, earlier this year, ANCAN ran a survey of nearly 170 men on active surveillance. And one of the questions had to do with the impact of anxiety. More than 30% of you said you were anxious, especially at times when you're waiting for test results or around the time of biopsies or PSA testing or office visits. You know, it makes sense. But anxiety can also be a reason that some men leave active surveillance, men who are not threatened by progression of their disease. And, you know, it kind of raises the question, so should surgery or radiation be a treatment for anxiety? Well, lucky for us tonight, we have an expert to speak about anxiety and active surveillance, or what some of us call anxious surveillance. And tonight we have Dr. Andrew Matthew, lead psychologist in the departments of surgical oncology and supportive care at Princess Margaret Cancer Center in Toronto. He's been there for over 20 years, and he's been studying men like us and with men with similar problems. And his topic tonight is walking around with cancer, the psychological burden of active surveillance. And with that, I turn it over to Dr. Matthew.
All right, great. I'm just going to try to share my screen then. And Howard, I'll just check with you. Can you see the screen?
I got to shift back 1 second.
All right.
Yes.
Yeah, it's coming up fine.
Okay, super. All right, well, thank you very much for the very kind introduction. And I just have to say, it's a real pleasure to speak to this group tonight. I talked with Howard a number of months ago about actually the survey that he was just describing, and he invited me to speak, and I thought it'd be a great opportunity. I'm going to, luckily, actually, I was able to chat a little bit with Howard back and forth and Joe, and it's clear to me that this is a very well-informed group. Even you know, some of the new members just participating in the group may find it extremely helpful. I'm going to talk, as I said, about active surveillance. I'm going to give you some of the background, many of which you know, and then I'm going to kind of do a right turn. And I'm actually going to talk about anxiety itself and how people recognize what anxiety is and what to do about it. So it's a bit of both kind of a combination, you know, academic, meaning at the beginning we'll talk a little bit more academically, and then more in the second half more on a clinical level. So we can just start with prostate cancer. And I think many of you know this, and I've got the Canadian statistics here and the statistics from the US. About 23,000 men will be diagnosed with prostate cancer in Canada, and about 250,000 will be diagnosed with prostate cancer in the United States. The lifetime diagnosis rate, about 1 in 9 in Canada, 1 in 8 in the United States, and that's been kind of shifting around over the last decade. But I think the bottom line here, the 5-year survival rate for most people with local or regional prostate cancer is nearly 100% in both countries. Prostate cancer mortality in the US has fallen by about 40% since 1993, and probably the two most probable reasons for this reduction are early detection, such as PSA testing, and improved treatments. Here you can see there are a number of treatments: radical prostatectomy, robotic radical prostatectomy. These are radiation, external beam radiation, so intensity modulated radiation therapy, which is IMRT, and volumetric radiation therapy, VMAT. Brachytherapy, which is seed therapy. We have a number of different types of focal therapies available both in the United States and Canada, including laser therapy and high frequency ultrasound. And then we have androgen deprivation therapy that can often be used in combination therapy for localized disease. So, and there's been some significant advancements. The big ones in surgery are the introduction of the robot and radiation. When I first started a number of years ago, they had external beam radiation, it was called, and then 3D conformal radiation therapy, then IMRT and VMAT. So the technology has been advancing, which means we're getting better and better at treating the disease. However, due to the sensitivity of PSA testing, it's known that many newly diagnosed men had biologically indolent disease, non-threatening disease, and are unlikely to die from prostate cancer. Modeling studies have also suggested the risk of PSA detected prostate cancer being overdiagnosed is about 67%, leading later to overtreatment. So we also know that treatment results in side effects that negatively impact health-related quality of life. And so what's clear here is that we're not going to say that the PSA and early detection is such a negative thing. It actually has done some remarkable, it's been involved or contributed to producing much better mortality rates and benefit, but it does also result in this overdiagnosis. So because of that, we were at the very least clearly overtreating prostate cancer as active surveillance was really not part of the scene. So the possible solution to the fact that the PSA testing had become so successful in detecting these early cancers, but to avoid overtreatment would be something like active surveillance. Here, there's just kind of a brief description of what would make a patient eligible for active surveillance. Don't hold on to this one too tightly. There are a fair number of different ones across the United States for sure, differing in internationally as well. So it just gives you a flavor for the defining of mainly localized disease or fully localized disease. So what led to the uptake of active surveillance, or what is the uptake of active surveillance? If you look back in 2004 to 2006, only about 10% of low-risk patients were managed via active surveillance. In the US, between 2010 and 2013, this is out of a 2018 paper by Laurie Klotz here in Canada, 40% of low-risk cancer cases were managed via active surveillance. And among men over 75 years of age, the rate of active surveillance in that population was about 76% during this period. So you can see that active surveillance is becoming more and more prevalent in terms of considered treatment in prostate cancer. There is significant variation in the uptake of active surveillance across American practice sites for sure, and that is also true in Canada. And I thought the registry from the Michigan showed active surveillance uptake practices differed significantly just within Michigan, 27% in the low end, up to 80% in the high end across different practices. Globally as well, multiple studies report reductions in patients with low risk disease undergoing radical prostatectomy. A good example here is in Sweden. In 2000, the kind of shift from 2009 just to 2014, so a 5-year shift, low risk patients were managed via active surveillance, increased from 40% to 74%. So what are the factors that influence active surveillance uptake, and also what are the experiences of our patients that actually undergo active surveillance? And I did some work in this a few years back, and what we found was that the single greatest influence on whether patients were going to move on to active surveillance was the urologist you can see here. So the urologist had the biggest influence for encouraging or to recommending patients to go on to active surveillance and patients feeling confident to do so. Interestingly, patients that chose radical prostatectomy as a treatment, friends had a significant influence on their choice, which was not true for active people on active surveillance. And then also what is interesting from our study is that it seems that the kind of TV and radio, newspaper, kind of the media education did have an influence, so that patients seemed more confident in shifting to active surveillance. And we can see that there's actual difference in terms of that influence compared to patients with radical prostatectomy. If we look at the aspect of anxiety and depression, so the theory would be that maybe patients that are more anxious will be less likely to go on to active surveillance. And if we use our kind of basic standardized instruments to detect this, then the theory is that there's no difference, that patients don't seem to be more anxious than patients, for instance, that choose active surveillance. So the idea being is that there's no real difference between these patients at the outset. And these are the kind of standardized questionnaires. The STAY looks at anxiety. The CESD looks at depression. And then we have the PANIS that looks at negative and positive affect, and it just was not able to detect any difference. However, when we did our work, we asked much more specific questions that was kind of like specific to the patient experience as opposed to global anxiety. So we asked about, do the patients experience, what is the experience of fear of dying there in terms of not at all to very much. You can see the numbers there. Fear of metastasis, so fear of spread of the disease, erectile dysfunction, and having a tumor in your body. And you can see that prior to treatment, so as something, they had a real fear. It was radical prostatectomy patients, the one in red, seemed to have greater fear of dying compared to the active surveillance, greater fear of metastasis, greater experience of fear related to having a tumor in the body. And so you can see that these fears may very well have moved a patient into going for radical prostatectomy compared to the active surveillance population. So urologists have a great influence on patients choosing active surveillance. Radical prostatectomy patients report greater anxiety related to fear of dying, metastasis, having a tumor in the body, and erectile dysfunction. Patients on active surveillance actually experience fewer physical side effects. I didn't provide you with those results from our paper, but that's certainly obvious and also well reported in the literature. However, this talks about the experience of patients, or what we can detect from patients in the uptake of active surveillance. What is the experience for patients that are actually on active surveillance after making that treatment decision? And so if we look in the literature, the suggestion is there's no statistical significant impact on survival and mortality. For those that are on active surveillance with localized disease and those that go on to a more invasive treatment, active surveillance patients experience less impact on their quality of life, as I just mentioned. The majority of studies report low levels of anxiety and depression in patients on active surveillance in general, and the majority of active surveillance patients experiencing decreasing anxiety over time, which does make a little sense. If they do have some anxiety, it decreases over time because we're incredibly adaptive creatures, and we can get used to our new normal, so to speak, and the anxiety lessens. As Howard mentioned, there is some level of patient where the active surveillance patients may shift to more invasive treatment due to anxiety or psychological distress, as opposed to due to disease progression, and that range is about 2 to 18%. There's not a lot of research in this area. So if we were just to read this, it would certainly seem that everybody on active surveillance is just fine. They have no difference in mortality. Their quality of life is better. They don't seem to have any more anxiety or depression than any of the patients in other receiving other treatment. But that's fine. But still, the question remains: what is it really like walking around with cancer? So instead of just, as we did, look at the standardized questionnaires, we asked much more specific questions again to this patient population in terms of what it's like while being on active surveillance, and the worry about dying. We have about 30% say that they worry more than they did before their treatment. This is active surveillance, and worry about future health more than they did before treatment as well. So in some sense, it's interesting in that prior to treatment, the patients that chose radical prostatectomy were more worried, but then after treatment, they're less worried. So the idea of actually having the cancer removed and treated gave them some sense of safety or security that they were going to be fine in terms of worry about future health and dying. It does appear that active surveillance patients carry a little more worry about dying and about future health. And this makes some sense, meaning, of course, that the other patients who had the radical prostatectomy are believed they've been cured of the disease, whereas the active surveillance patients are carrying their disease. The only caveat here is those that underwent the RP, they might be carrying indolent disease, and they're going through the quality of life side effect profile, which certainly may be more challenging on its own than this specific health worry that you can see here for active surveillance. Interestingly, as Howard said, Howard shared some of the findings from the active surveillance trial or survey that they put out, and this was the AMCAMS2 and active surveillance patients, about 165 patients. And on the left it says, "Are you anxious on active surveillance?" 165 responses, and we found about 33 to 34% said yes. And then the same question asked, "Were you anxious before diagnosis with prostate cancer?" And about 15% said yes. And so the idea is that then we would assume that prior to going on active surveillance, about 50% were anxious, and then this increased to 30%, which is a 15% delta. I still say that's an important delta, absolutely, for sure. And then if you remember, just looking at our findings, we find that it's more, it even describes probably about 1/3 of patients do experience some level of anxiety, depending on what we're talking about. When do the patients experience anxiety? This is from that survey, and you can see that around a PSA test, so that's PSA-itis, I think they call it, where fear of the PSA test is quite high, and also when they're waiting for their test results, which makes a lot of sense. we take a look at what have you found most challenging about being on active surveillance, and similar to our questions and our results, they look like anxiety about having untreated disease, and then also fear of disease progression. So walking around with cancer kind of looks like that there is this worry in about 30%, but our standardized questionnaires maybe are not picking it up, and hence that's what we see in the literature. But anxiety, like any other health domain, is on a continuum from uncomfortable to severe anxiety. And few patients, I can imagine, can say that being on active surveillance does not result in some anxious moments at some time. I think one of the things I call is the billboard effect, where if you happen to see a billboard that says, you know, please give to your local cancer center, it's likely that that may trigger a reaction that, of course, a reminder that you're carrying cancer and that you're on active surveillance, and that can create some anxious moments or even greater anxiety. So how can you walk around with cancer and experience anxiety less often and with reduced intensity? In other words, reduce the amplitude and the frequency of that anxiety. What I'm really getting at is that it may not be picked up in the literature as much, but having worked with patients for a long time, including active surveillance patients, it is, you know, you kind of lose a little bit of that sense of being carefree because you know that you're carrying the cancer, and so it can create anxiety. So what can we do about that? And this is where I'm going to kind of take that sharp turn, and the answer is really to get to know anxiety and then to get to know how we cope. And what I'm talking about is get to know anxiety in general and get to know how we cope, and then we can utilize that for how we cope with any anxiety when we're walking around with cancer. So the first thing to think about is to really reflect on the fact that we all have a limited capacity to cope. So our ability to cope is not infinite. Our coping vessels, unfortunately for those on the phone, they can't see, but I have pictures of a glass of water being filled up. Our coping vessels can only hold so much. And so just a reminder that it doesn't matter who you are or how strong you are. We can't just cope with everything, at an infinite level. We do have that limit. So the interesting thing, and people don't really think about this necessarily, but the diagnosis of prostate cancer and actually being on active surveillance doesn't really release you from your usual stressors. So it's kind of like it's added on to the usual stressful life that we have, being an attentive partner, parenting or grandparenting, work demands, how to deal with COVID, finances and taxes, traveling abroad, volunteering, organizing a social occasion. These are all stressors. Even though traveling abroad, of course, sounds pleasurable, it's also stressful to do and stressful to organize. And so we carry a lot of stressors, our usual stressors, that amount to about 3/4 of our coping vessel. About 75% of our coping vessel is generally full with our usual stressors at all times. And then that 25% acts as a buffer left over. So our buffer does allow for incidental stressors. So a good example is that I would say my coping vessel is about 75%, but if I'm driving down to the hospital and I look down at my stereo for a moment to see what song is playing, I look back up a little late and I bump into the car in front of me. It's just a little fender bender, no one's hurt, but that's a stressor. And what happens is that it absolutely adds stress to my coping vessel. However, because I have my buffer, I can manage that without feeling overwhelmed, as my coping vessel can, for instance, manage it. It's not too much for me to manage. Coping with active surveillance, however, requires a lot more space than a fender bender. So the idea is, of course, the diagnosis and moving to active surveillance and determining whether this was a good decision and can you be monitored well enough, and are you going to have disease progression, and Have you made the right decision? Are you going to have decision regret? That's a lot more than a fender bender, and that gets poured in and potentially requires more space than is available in our ability to cope. And when our coping vessel becomes overflows, we become overwhelmed, and we have a real sense of feeling out of control. That the comment about feeling out of control is going to be a common theme from this point forward, so keep that in the back of your mind. But in essence, the sense of feeling out of control is anxiety, and it's extremely important for us to protect ourselves and our coping capacity, our coping vessels, from becoming overwhelmed, because it's harder to get back on solid footing if you become overwhelmed than it is to try to prevent yourself from actually becoming overwhelmed. So when we take a look at approaches to coping, and remember, I'm talking about active surveillance more specifically, and I will at the end, but this is really how we approach coping in general for the stressors that we experience in life. So what can be helpful? One is a much better understanding of anxiety. What do we mean by anxiety? And then making space for major stressors so that that we don't get overwhelmed, that we just don't keep adding stressors on until we can no longer manage. And then identify anxieties and organize them according to controllability. So there's that word again, control. And the idea is some stressors are kind of more in our control and some are less in our control. And we need to identify which ones we have some control over and which ones we don't. And we can, by doing that, it helps us understand which type of focused coping we should use, or what's going to be most successful in terms of ones that we have more control over versus ones we don't. And there are three kind of layers of coping that's called problem-focused coping, emotion-focused coping, and meaning-focused coping. So I'll be talking about that. But Howard asked me yesterday, what is anxiety? What's the relationship between anxiety and depression? And it's a very good question. And really, in essence, anxiety and depression certainly are different mood states, of course, but they are two sides of the same coin. If I'm teaching my students and I'm talking about anxiety, and when I'm talking about anxiety, I'm talking about everything from generalized anxiety disorder, post-traumatic stress disorder, obsessive compulsive disorder, panic disorder. Those are all anxieties. And at the root of all of those anxieties, the underpinning of those anxieties are difficulty dealing with lack of control, difficulty dealing with uncertainty, and a sense of helplessness under those conditions. On the flip side, depression is really the kind of main pillars of depression are despair, which is quite different from sadness. It's on a continuum. Sadness is about here, and despair is right at the pole. It's a long way, and it's a very devastating experience feeling that level of sadness and despair. And then a sense of hopelessness, a sense of worthlessness, a sense of guilt, and a sense of shame. So under those conditions, that probably would best describe depression. Now, if you're depressed for a long period of time, that can also lead to anxiety. So if you're depressed and you stay at home and you're withdrawn and you stay kind of shut in on your house for a long period of time, and then you're starting to recover and you need to return to work or return to life outside the front door, it can be very anxiety provoking to go back out that front door. So depression can lead to anxiety. Similarly, anxiety can lead to depression. For instance, in many cases, we don't like lack of control or uncertainty. One aspect of public speaking is that, yes, you're the center of attention, but you can't control the situation as well. You're not sure how well you're going to do, but also what the response is of the people listening to your talk. And because of that, you may choose not to speak, do these public talks or speak public presentations. So if you're at your work and promotions rely on this, you may avoid getting promoted. because you're unwilling to do these presentations at meetings, and then you're not meeting your potential, and that can then start to hit a sense of your self-worth, and then that anxiety, the avoidance that you experience due to the anxiety can lead to depression. So one can definitely feed into the other. So that's kind of the background. I hope that helps, Howard. But just to remember that these are the real pillars of anxiety. That's what we're talking about. Difficulty dealing with lack of control, difficulty dealing with uncertainty, and a sense of helplessness in this. And so you can see that the core aspects of anxiety certainly can confront patients that are on active surveillance. So to continue with our understanding of anxiety, one of the things is that we forget, and that is anxiety is actually a response to threat. So you have threat, and then you have fear, and fear equals anxiety, and so that's really the nature. That's simple. And then we have uncertainty or lack of control and a sense of helplessness. And if that gets to be too much and we're overwhelmed, then we become frantic, disorganized, directionless. We can't figure out which way to go to get ourselves out of this sense of discomfort. And we can even have diminished productivity, all of which, by the way, once you get that going, starts to rotate in a direction to increase your anxiety. It's hard to get out of that cycle. So what we want to do is really focus on avoiding that or working with that sense of lack of control and that sense of helplessness. The next one is to make space for major stressors, identify your usual stressors, prioritize those stressors in terms of which ones are most important, and organize your stressors. And this is a simple practical task to do. If you think about everything that's on your plate and you're feeling anxious, then really kind of listing all your stressors and take a look at what needs to be done now, what can be delayed, and what can be dropped completely from what's on the table in front of you. Remembering, of course, that just adding active surveillance into your usual life can easily overwhelm you because you just haven't made space for it. So by doing so, you can increase your buffer, and that allows you to cope more successfully with the diagnosis of prostate cancer and moving on to active surveillance. A third step is to identify what's controllable versus not controllable. Back to the word control, right? Take some time to identify what concerns are causing your stress to anxiety. Divide those, right, anxieties into what is controllable and what is not in your control. So mainly in control, somewhat, or not in control. And knowing this will help us choose the right coping strategy. So finally, then once we've determined once we determine the stressors we're going to work on, and we've determined the level of their control, how much we're in control of them or not, then we move to these empirically based coping approaches. One is problem-focused coping. These are strategies that are focused on the problem itself. There's emotion-focused coping, and these are strategies that are focused on the emotions related to the problem. And I'll show you this in kind of a graphic in a moment. And then there's meaning-focused coping, and that's the kind of the most advanced, deepest form of coping, where you're looking at meaning of the interaction between you and the problem. So the most effective coping response to a powerful problem or a powerful stressor, like active surveillance, is to combine all three approaches. So problem-focused coping, just to give you an idea, that's based on kind of the rational, logical. It's like the critical thinking and the problem thinking. So it's often the way we will handle problems or stressors, and we break them down into their smaller parts. We brainstorm on options that can help us address the problem. We identify the pros and cons of each option. We narrow it down to the best option you have. You begin to solve the component parts, cross off the task, and solve the problem. So this problem-focused coping approach is stereotypically male or masculine approach to coping. It's that we only focus on the coping and not really on the emotional impact of that. So on the stressor and not the emotional impact. Problem-focused approaching is designed to maintain control and mitigate uncertainty. So I call them the big five. when a problem or a stressor arises, and I use a problem-focused approach, it's 720-degree decision making, which means you assess or critically analyze the stressor and taking a look at all the risks associated with it, determine what we can do about those risks and mitigate those risks. Then we use our intelligence to hone our skill. We use our experience to date to help inform our decision. And then we use our discipline. Imagine, some people are more inclined to do 360-degree decision making versus 720, but those that are really kind of perfectionistic or need that control in their environment will do the kind of full 720. And in order to do that in an efficient way, they have to be highly disciplined. This is not uncommon for instance, a lot of executives or physicians will carry this trait because, of course, they try to maintain as much control in their environment as they can, and they try to avoid all mistakes as possible. So in a problem-focused coping approach, you do 720 decision-making, intelligence, experience, discipline, and skill. So let's say the problem is simply, or the stressor is, what car should I purchase? And it's still a stressor because you're spending a lot of money. So what you do is you launch your big five and you take a look at it and you do exhaustive research and analysis. You look at the pros and cons, you weigh the vehicle's attributes, you look at price comparables, you look at her previous experience with the cars and perhaps the auto manufacturer, you consult with a vehicle expert, and you do all of that, and you can solve your problem. And of course, the answer is you should always buy a Honda Odyssey, and away you go. All right. So the idea being is you got a problem-focused approach to a stressor. But what happens if the problem has no solution? And this is the challenge, and this is a little bit of the kind of a little bit of a left turn now again, and that is that a diagnosis of cancer really doesn't have a solution. And so what we can do is we can get caught in the idea of trying to use a problem-focused approach where we break it down into its component parts, and we use our intelligence, experience, and discipline and efficiency to make a certain decision. But unfortunately, unlike making almost a certain decision on the car that you buy, there is no certainty in cancer, and that's the challenge. And so instead of just using a problem-focused approach, it's a transition to also using emotion-focused coping. So it's a shift from solving the problem, which is not fully solvable and beyond our control, to focusing on the emotional response to that problem. All right, so here's the problem with no solution, and we have an emotional response. We can still employ the problem-focused approach. So using the diagnosis of cancer, we need to do research, we need to find the best oncologist. It's a good idea to get a second opinion. We take a look at what's in our control, perhaps diet, exercise, and stress management. That will help, but it won't solve the problem, right? It still is going to be a problem, and it's going to be something that we have to cope with. So we can then say, all right, we can't solve the problem. There is always uncertainty and some level of lack of control in being diagnosed with cancer. So now I want to focus on my emotional response to that. So not directly focused on the cancer, but what is my emotional response? So it's where I need to work on the here and now, recognizing that the draw of cancer is to pull you into the future and create anxiety about your mortality and your longevity on this mortal coil. And so we need to try to avoid always living in our future in that fear space. Tolerance of uncertainty is really important. Is that we in fact always are living with some level of uncertainty. We just don't recognize it. In fact, we think we're in more control of things than we are. There's always been uncertainty, and we have varying degrees of tolerance of that, and we can teach ourselves to tolerate uncertainty more successfully. And then establish realistic hope, and that is the idea that yes, you have a diagnosis, but is this going to change your life forever for the negative? And are you fearing the outcome? what you can do is that you can establish much more realistic hope, the idea that you can remain hopeful in a realistic way rather than in denying it or becoming overly absorbed in it. And then finally, there's the meaning-focused coping, and this is the most advanced. This is kind of an existential exploration. You know, all of you guys are on active surveillance, may have been on active surveillance for a long time, but if you remember the initial diagnosis of cancer, for everybody, cancer equals death right away, and then we can sort of adjust out of that. But it is a recognition of our mortality, and in so doing, we can undergo some exploration of what the meaning of life and death is. What does the threat of death mean to us? And by employing the problem-focused approach, along with the motion-focused approach, along with this kind of existential exploration, we can actually reduce the anxiety or stress. Notice the problem is not disappeared, but it's faded in color, meaning it's faded in its strength, in its amplitude and its frequency. So if we take a look at that approach and we employ that type of approach into active surveillance, which is fairly close to the idea of what we just talked about in terms of being diagnosed with cancer, so there's a lot of similarities, but making space for active surveillance and anxiety, identifying your personal active surveillance anxieties and organizing them according to controllability, and then employ the focused coping that we just talked about. So one, prioritize the stressors. So here's the stressors that I listed in the first slide earlier on. And if we set more realistic expectations of ourselves, recognizing that we can't just add the cancer diagnosis and active surveillance onto our life as it was before without threatening being overwhelmed, what we need to do is prioritize and be more realistic about what we can manage, at least in the transition period. So we can still focus on being an attentive partner, parenting, COVID, finances, and taxes. But for instance, we can have some control over how much work demands are going to be part of our stressor, or traveling abroad or volunteering or organizing social occasion. We can reduce our stressors to make more space as we adjust and acclimatize to being on active surveillance. Remember, I talked about being controllable versus not controllable. If we look at mainly not in your control, disease progression, PSA test results, no amount of worry is going to change those. So that's not really to a large degree in our control. Somewhat in our control is future health and our response to COVID. More in our control is our finances, work demands, because we can be disciplined in work or choose to reduce our work. And then being an attentive partner and parenting and grandparenting. So you can see that we can kind of put it on a continuum, what we have control over and what we don't. And then what we have control over, where we have control, we want to use the problem-focused approach. So we want to do the research and analysis so that we're well informed about our risk perception, so that we don't have risk distortion, which can be very important. And then we can employ really strong self-care approaches to help manage our anxiety, regulate overwork, which is very common, have exercise and yoga, unplug from social media, progressive muscle relaxation and deep breathing, meditation, mindfulness, self-compassion. So the idea is that having active surveillance may in fact, because it does carry some burden with it, may in fact cause lower energy or even some fatigue, and it means we may not be as productive as we're used to. The other thing is that this is more likely to occur shortly after your diagnosis and choosing active surveillance, because you're still processing the trauma of that. And so the idea is that don't have the expectations you're going to achieve the levels of productivity that you did prior to knowing that you had cancer. Also access your social support system. You can rely on others as well. Emotion-focused coping in terms of active surveillance, remembering that accepting that you have cancer and that you'll be living with the cancer and you may not have control over how and when you die, that accepting and adapting is not giving in. In fact, it's the opposite. It's a stronger approach because it allows for this tolerance of uncertainty so that you can live in the uncertainty without the anxiety, and remembering that no amount of worry will affect the actual outcome. Challenge yourself to stay in the present. A good saying, let go of yesterday's regret and tomorrow's uncertainty. In psychological babble, what happens is that the here and now is where we actually have control, and we can actually feel, have the emotional experience. We can feel it. We can feel joy and peace and pleasure. When we're ahead of ourselves and think to our future, by definition, that can create anxiety. And remember, so future-oriented thinking brings about anxiety. Past-oriented thinking can bring about depression. The future-oriented thinking can help for planning and the like. But remember, you can't experience the emotions, pleasurable emotions, in the future. You can only experience that now. An example of that is you book a ski trip, you can look forward to it, but you can't actually feel the experience of enjoying the ski trip until you're there. So trying to stay in the present becomes important, and we only have control over this moment. Also, normalize emotional responses to extraordinary threat, accept and normalize vulnerability. It's much better than denying the emotions associated with it, although it can sometimes take some time to process. Cognitive reappraisal: thoughts are not facts. Many are simply beliefs. So given statements and automatic thoughts, can drive a car, so they can certainly drive your fear. If we think about that, when you're driving a car, you're very rarely thinking about all the rules of the road and your leg on the brakes and the thing. It's kind of automatic. If I ask you to tell me exactly what's going on, you can, but other than that, it's really kind of automatic. In the same way, we can have automatic thoughts that drive our fear. They're that powerful. Accepting and adapting, I'm not giving in, that was to be erased. And then also think about what you would tell loved ones to ease their worry, and that can help understand how you can also be self-compassionate for yourself. And then the meaning-focused coping. Challenge yourself to stay in the present. Let's let go of the yesterday's regrets. As I said, reflect on the degree of control we all have over our health. And so this need for control, this that we talked about before, the kind of big five, the idea is that we have less control, or the big five is not very helpful when it comes to our health, and it's not very helpful when it comes to other people, because we don't have as much control over his health as we wish we could, and we don't have control over other people because other people are very complicated. That's a good thing, don't get me wrong, but the idea is that can create anxiety. And so our desire to feel like we have control over our health, we kind of shift to a fantasy of omnipotence. So when we're 15, 16, 20 years old, we just assume we're going to live forever, at least until 90, and that seems like forever, and it doesn't create anxiety. But it's really just a fantasy. You know, the poor kids in the Humboldt bus crash here in Canada didn't know that they would wake up in the morning and not be living in the afternoon. So the idea that we had that control was just a fantasy. Now, yes, being diagnosed with cancer, you have some idea of what the risk could be, but in a very same way, you never really had control over your health as much as you thought you did it in the first place. And this can help you understand that you've been living in an uncertain world up until the time of diagnosis, so you can still live in an uncertain world afterwards. Reflect on facing mortality and the meaning of life as well. It's we don't like taking a look at our mortality, but as we age anyway, we start to recognize that life is not limitless. And it's worthwhile to look at the meaning of life. And having worked in a hospital for 25 years, I can tell you that the meaning of life really is the relationships you have with the people you care about most, and that can be something that you can focus on. So successful coping is where we make space so that we can include our usual stressors and our active surveillance combined within our coping vessel and still have a buffer so we can manage incidental coping. And remember, if you don't take care of yourself, you can't take care of anybody else. So it's very important to make sure that you don't allow yourself to become overwhelmed, because then it's not only it's difficult on you, but you can't, or you don't have the bandwidth to help others. The ANCAN Us Too Active Surveillance Support Group, you're all together in this. And as Nelson Mandela said, as we are liberated from our own fear, our presence automatically liberates others. Thank you very much. And I will bring us back.
Well, Andrew, Andrew, thank you so much, and for sharing approaches that we can take, to kind of put us in a better place, and not to let anxiety get the better of us. Now, let's see, we're going to take a brief time out here because we have some housekeeping. Mike Scott has been having trouble getting in, and if he doesn't show up in a minute, I have authorization to pretend to be Mike for a minute. Meanwhile, we also have a message from Rick Davis, who is here, but I can take care of it. And it's actually some interesting news having to do with Bayer and Pfizer Oncology are co-sponsoring all of our regular support groups, although not the webinars. And ANCAN believes that this is the first time that these drug companies have sponsored virtual support. And and there's a 12-month sponsorship for all of our prostate cancer support groups. And, that includes the active surveillance group, which is going a long way, because I can tell you personally, making the rounds with the drug companies, that active surveillance wasn't going to sell them any drugs, and they weren't too interested. And what I argued was, that they should take a community approach to this, because maybe 1/3 to 50% of men on active surveillance will end up being treated. So it would be great if they could support us. And I guess Rick has succeeded with that. And so congratulations to ANCAN and Rick, and to Bayer and Pfizer Oncology groups. So I think that should cover that. And then let's see, has Mike showed up or no? Let's see.
No, I haven't seen him yet.
All right, well, I'll be Mike for a minute. Some of us know Mike, a lot of us don't. Mike is a guy who was involved with active surveillance before there was active surveillance. Funny enough, he was a drug company guy who took an interest early on the idea of what became active surveillance. And so he, for 25 years or so, has supported the concept and has worked behind the scenes on a lot of things. Now, some of you I know will not think this is a benefit, but he more or less recruited me to get involved, and had me become the first man on active surveillance to speak to the ASCO genitourinary seminar in Orlando. It's a whole other story, but Mike was the catalyst in getting me involved, and that's what led to working with Rick and creating this meeting, and also creating the ASPE group. So Mike is a person to be heeded, and I went with him back in maybe 2018, and we went to the Prostate Cancer Foundation looking for funding for a project to look at the future of active surveillance, and finding the right questions to ask to get to the future. And we talked to the scientific director at the Prostate Cancer Foundation, which I call the Advanced Prostate Cancer Foundation, but that may be changing. And the scientific director said, well, more or less, he'd be fired if he gave us money. But I think things may be changing. They have a new administration there. And but Mike, meantime, got funding from the PCORI group, the Patient-Centered Outcomes Research Institute. And what he's done with this funding is to create a virtual conference coordinated through the University of Maryland and supported by a grant from PCORI. It's designed to define high priority research questions that will assist patients and their doctors to optimize the application. This sounds like an application for a grant, doesn't it? Application of active surveillance in the management of favorable risk forms of prostate cancer. It will bring patients, physicians, and researchers together to identify such questions and frame them according to specific standards for health-related research. Okay, formal registration to attend this meeting is coming up, and we'll be back to you with the URL for that. And patients and caregivers are giving input to this topic. And I should mention Joe is involved, and Judy Walensky, Mrs. Walensky, came into the service of active surveillance to some degree. And so this event is going to be December 13th and 16th. And as Mike said, more details will follow. Now, at any rate, now, Joe, is there any other housekeeping or should I keep going? Joe?
I think that should cover it, Howard.
Okay. All right. So I'm working, I hope, with Jim Schraite tonight on some questions. And one of the things that came up, Andrew, was a question from the boss, Rick Davis. And he's asking, what is 720-degree decision making? So can you give us a definition? Andrew.
It's just on mute. Yeah, it's really just kind of a description of the idea that if we think about decisions, how we go about decisions, we'll put a certain amount of effort into determining how we want to make that decision and what we believe is going to be the right decision or closest to the right decision that we can make for us. And so the more we investigate that, the more we can make that clear. So the example of, for instance, buying a car is that doing a lot of investigatory work and talking to people that own them, it's where you can find out more and more and more, so you feel more and more confident in the decision you're going to make. And you also take a look at any risk associated with decisions so that you can mitigate that risk. And so it's the 360 is really, let's say, what a lot of people will do is just kind of a 360 degree on a decision. I'm really referring to 720 as being even more diligent in the decision-making process. And this often anxious people will do is that they will take a long time and investigate a decision, and it can be even difficult for them to make decisions unless they can do these full exhaustive searches as to what would be the right and wrong answer. It is referred to in the literature as perfectionism, right? And believe it or not, perfectionism actually falls under the umbrella of anxiety because of the need to make sure that you've made as close to the right decision as you can, mitigating all risk.
Now, we had Dr. Klotz here recently, and I can't remember if it was at that meeting or some other one where I was talking to him, but he was saying that the urologists, and I can tell you myself, the family physicians too, are a source of anxiety. Klotz was getting at, that maybe some of the doctors over the border, at least, where the healthcare system is different, they're going to be having more of an incentive to do surgery. So they possibly are leaning on the patient to have surgery. And I'm just wondering, from your point of view, U.S., Canada, wherever, uh, how much anxiety is induced by our doctors?
Well, I think it's a very good question in that we have to first of all take a look at remember there are two parties in this, the patient and the physician, and we have to take a look at the risk tolerance for the physician as well. So when it's a negotiation, or it can be a negotiation, what we want it to be is a negotiation where we take a look at the risk tolerance of the patient and the risk tolerance of the physician, and they have a discussion about that. Unfortunately, there still seems to be this the pedestal. So the idea is that the physician, let's just ask the physician whatever the physician says we'll go with, and then you're really relying on that physician's risk ability to manage risk or risk tolerance. So some physicians here, for instance, and Lori Klotz was one of the first, is that, when we first took a look at active surveillance, we were only working with Gleason 3+3, and everybody was very tentative. And then we started to shift to 3+4. But I think there were certain doctors that would shift at that level that were more comfortable or less comfortable. We also take a look at the degree of influence that doctors have. So when we took a look at some of the results that I was showing you, the majority of patients are on active surveillance because that has been a recommendation of their urologist or their physician. So they're very powerful in their influence, but the degree to which the system allows for the physician and the patient to have those types of discussions in terms of what they're willing to allow for risk. First of all, time doesn't even allow for that. But absolutely, what I think there was a question in the chat box of what do I mean by overdiagnosis, and what that really refers to is the diagnosis that using screening instruments, the diagnosis of a disease that will that has no side effect and will not cause you harm. And so we know that is true, certainly in prostate cancer, yet a urologist's opinion about, or a physician's opinion about that disease and what they feel comfortable prescribing is really up to the physician. So imagine that patients are usually responding to the risk tolerance of the physician, not even their own risk tolerance.
Maybe I'll ask just two more questions, and then I'll ask Jim to dive in. But okay, you said two parties, the doctor and the patient, but really there are many parties involved, and maybe you can comment on that. Sometimes I call it a couple's disease, and that's just the most immediate impact. The spouse has a say in this too, because it's a couple that's facing it. It's not just you, the patient. But also the daughters get involved, the sons may get involved. But can you talk a little bit about the impact on the patient of these other influences, and how do you deal with anxiety maybe provoked by your spouse or your daughter saying, Dad or honey, how can you not have surgery? You got to get that cancer out. So, I mean, is it the 720-degree approach, or is there something?
Yeah, it's a good question.
More?
So it is true, Howard, that and absolutely. When I was referring to that, there's the patient and the physician. That was just to simplify the aspect of,
Sure.
of anxiety and risk. But absolutely, it can be certainly if the patient is coupled, it's known as the couple's disease, but and oftentimes that's related to the sexual functioning problems, really, every cancer is a couple's disease, right? Because if you love somebody and they're affected by cancer, it's going to affect you, and how the two of you are going to manage it. And so there is a very big role for the people that love you to be involved in the process of the diagnosis and treatment decision making and treatment outcomes. The challenge is that in our actual research that I was showing you there, interestingly enough, friends seem to have more influence than spouses, but the sample size is not strong enough to really go that way. But it was interesting that I didn't show you the non-statistically significant results, but spouses did not seem to have that strong an influence, or at least a differential influence between active surveillance and the radical prostatectomy group. That said, having been working in this area for some time, and just as you said, Howard, is that a lot of patients on active surveillance will say that it's they're okay with it, but it can be very difficult on their family and on their children, and even on their even they'll get some real pushback from their friends. And so in the very same way that the medical system needed to really work hard on educating the public about PSA. So I just looked in the chat box, and you could see there was lots of controversy, lots of discussion about PSA. PSA in and of itself is not evil. The PSA that as long as we don't have PSA results automatically moving us in directions like you get on a treadmill and you can't stop, that's not going to be helpful. The idea is education around PSA so that we know what we do with those PSA results, and then we can know what we can do, similarly. So the making sure that the people that you love that have some influence on your decision making, making sure they're engaged and join you in the hospital, so that they're present in your meetings, but also having very fulsome discussions with your spouse and your children, so that you can help move them to a place where they just don't think about cancer as death, and that cancer, you just got to get it out of you. And you can use lots of statistics from not only prostate cancer, but other cancers, that many cancers now have transitioned from those that have transitioned to a chronic illness as opposed to an acute life-threatening illness. And in the same way, we need to learn to live with that tolerance as well. So including your family and helping educate them and be patient with them can be very helpful.
Gotcha. Well, Jim, how about it?
Okay, well, you've answered the questions in the chat about the PSA, so thank you for that. And I think maybe we can move into some anxiety mental health questions. And I think the first one is, if a patient is struggling, thinks he has anxiety, are there warning signs that would indicate he should seek professional help? Or what are the early symptoms of anxiety? I mean, I think a certain amount of anxiety is just normal, but right. What do you look for when somebody's starting to get into trouble?
You got it. And so, one, I really appreciate what you said, that of course a certain amount of anxiety is just normal, right? Like, the idea is that, and then the question is, it's hard when we talk about active surveillance, because the idea is that I'm sure would have been your experience, is that when you're first diagnosed, before even going on active surveillance, that creates a significant amount of anxiety. You can even go through a PSA test and know that it's elevated, and then that you get sent to the doctors and you have a biopsy done, and you're going to go in and talk to your doctor. You think that you're prepared to hear that you have cancer because, you know, you followed all those steps to get there. And if you've done so, it's likely you're going to have cancer. But there's nothing quite like actually hearing the physician say that you have cancer. And that is, you know, very anxiety provoking. And as you said, that's a normal reaction. And we're unbelievably adaptive creatures. And when I'm talking to patients, I'll say, look, you're going to feel not better, but, you know, not fine, but you're going to feel a little better with your feet on the ground, even within about 3 days. And that's because we're phenomenal at adapting to even these kind of big threats. And it's the reason is that we need to be evolutionarily, we need to be able to start putting one foot in front of the other to start overcoming the threat. And that's precisely what patients do in prostate cancer. So that early burst of and definitely feeling overwhelmed is normal and natural. And then there's a processing of the trauma over time. And just as the results in the paper had said that active surveillance does, but patients on active surveillance, their anxiety seems to go down over time, and that's that adaptive mechanism. But and so you can feel anxious, you can have some level of anxiety, and periodically experience being triggered, and as long as you don't feel overwhelmed or out of control, that's kind of a normal processing of the trauma, and also the kind of living with the uncertainty or the risk. Where we can find anxiety be problematic, and early signs of that are almost always you'll run into sleep problems. Okay, so that's a good one. And the idea for that is that we're very good at distracting ourselves. And so we can keep busy all day as much as we can. But when we actually get into bed and we're in a dark room and we shut our eyes, we can't distract ourselves, and we're left with our own thoughts. And if we have anxieties related to being on active surveillance that we haven't processed enough, they'll start going, and then they'll interfere with your ability to sleep. So one is that. The other is irritability. So not unlike the cup runneth over, when we're near the edge of the cup, we can't take much other stress because we're anxious about the diagnosis and being on active surveillance. And so when little things can trigger a bigger reaction, so irritability and frustration that otherwise wasn't present prior to your diagnosis is also a good sign. Becoming overly involved in things and kind of detached. So the idea is that many men will become workaholics in order to just keep themselves busy enough that they're not thinking about it. That, you know, it's fine to distract yourself for acute levels of anxiety, but in order to process anxiety over time, you can't be in a constant state of distraction. So the simple and so there's that. The other thing is that signs of needing tension reduction. Okay, so the fact is that you're wound pretty tight, and then you get the diagnosis and you're wound even tighter. So if you can't manage the level of tension you're experiencing, some people become excessive exercisers. It's generally okay, not problematic. It's just a reminder that, you know, you're needing to exercise so much just to reduce your tension. But other less adaptive forms are increases in alcohol consumption or substance use. So just specifically sleep, frustration and anger, distraction, excessive work, and tension reduction, abusive alcohol or substances.
Thank you.
Jim, can I dive in?
Of course.
Okay. You know, I know a bunch of guys, and maybe some of them are in this virtual room. I really don't know, but I found a number of men were very secretive about their diagnosis. They don't want business associates to know. One guy is planning not to tell his mother because he figures his mother will die before he ever has to confront it. He also has withheld it from his teenage kids. And some people, for business reasons, they don't want to show a vulnerability somehow to their clients. Some politicians, I believe, are very secretive about it until they're pushed in a corner. But the thing is I wonder, in terms of stigma, what can you talk about stigma and whether that has an impact on anxiety?
Excuse me, sorry. Yes, and it's a very good question. I think it's important to recognize that there's not an absolute right or wrong answer to what you're talking about. So my advice to patients is that imagine, circles like concentric circles ever going out, and your most inner tight circle is your intimate others. Okay, so what's in that circle, the closest to you will be your parents, your partner, your kids, okay, are in that intimate circle. And then you have very, very close friends. And those close friends are one layer outside of that. There's one concentric circle out and quite close to the intimate circle, but just there. And then you have acquaintances, colleagues, and whatever, and you go out, okay? And in essence, I think it's important that patients believe and conceive that they own their diagnosis. It's theirs. However, with those that are in your inner circle, right, it becomes important to share with them that news. And the reason for that is that it can act as a trust breach, which is really unfortunate. So, for instance, if you have the disease and you have a son, and you decide not to tell them about the disease, and 10 years later you become very sick, and then the son learns that you knew about it 10 years beforehand, they're likely, and this does happen, but they get frustrated, they get angry because they weren't involved, and they weren't considered in those circumstances. I mean, it was done for a level of protection and care. But that intimate circle, it's where the intimacy is a sense of closeness and connectedness. It's being connected to your kids and your wife and your family. And as such, it's kind of the connection is bidirectional. It becomes very important to share that information. So I'm not saying it's a must, but I'm saying the recommendation would be that you share your information, your experience, your diagnosis, and treatment with those people in your inner circle. Remember I said the meaning of life is the relationships you have with the people you care about most. Those are those people, right? We all love our friends, and it's true. But our relationship with our brother is closer than that, even though our relationship may not be good with a brother. So it's getting a bit complicated here, but the idea being that inner circle becomes very important. And then the patient needs to think about how they want to approach people outside of that. In that you obviously want to include close friends if you can, because it's something you want to share with them. But it's not as easy as all that, because I can certainly understand why a patient doesn't want to be seen as, a prostate cancer named Andrew, right? He wants to be seen as Andrew first, who is carrying prostate cancer. So the way you can think about that is talk to trusted friends, because friends you trust will move to a place of allowing for the fact that you do not want to be seen as prostate cancer first and who you are second. But the further you go, challenging that. And so, and then there's in work, there's practical stigma, right? The idea is that if in the workforce you're as you have the disease, you may actually experience bias. So it's something to be thoughtful of. And depending on your work situation and who you tell in your work situation, helping them understand your cancer and what it means, and the prognosis and the likelihood that you'll live a good long life can become very important, and that will help reduce that stigma.
Andrew,
Gotcha.
if I may interject, this is Ira Lieb, Andrew.
Hey, Ira,
Yes.
Ira, why don't you, if you have a question, please submit it,
Oh, okay.
okay? Just trying to keep law and order here and don't want to take you away in chains again.
Okay.
So, Jim, yeah, please submit it. Yeah, Jim, do you have something?
Well, there was a question in the chat room, Doctor. I don't know whether you saw it, but it was a gentleman who was newly diagnosed with favorable intermediate risk group prostate cancer. And his question is, how do you define an active surveillance patient? Who should decide, the urologist, radiation oncologist, or myself? So the question really seems to be about the decision-making process for active surveillance.
Yeah. So there are guidelines. There were some comments. I think actually there was a comment that Howard has a paper specific to this. There are guidelines that we follow that define an active surveillance patient. They do differ, right? Like Canadian guidelines may very well differ from the United States guidelines, but as well, similarly, globally, they differ significantly. So, so one is that the oncologists are to be updated and informed about the guidelines on who can be identified as a patient that's available for recommendation for active surveillance, and so. And that is trying to be based as much as we can on empirical evidence. So the idea of, in fact, Dr. Klotz had done a lot of work in this area in Canada. And the idea was, okay, so let's start with this much more conservative presentation and then slowly determine whether we can go farther out and in Gleason 7 disease and the like. And that's all to be defined as we best we can from an empirical measurement. So it's reasonable to talk to your oncologist to talk about what would define whether he's whether I'm available or whether it's active surveillance is available or reasonable for me to consider. And they'll give you these guidelines and try to work within those guidelines. And those guidelines are based on empirical research, so they're fairly strong. They're not necessarily the ultimately correct because, of course, we're learning as we go. And so then the question is, let's say that the patient wants active surveillance and the physician doesn't believe that the patient meets what either the guidelines or what he or she feels comfortable treating. That's up to the physician, and they do get to choose who they treat. We wouldn't want to force physicians to do something they don't want to do. And so that means if you really feel that that you do want active surveillance and that you want to try to see whether you can talk to a physician that would agree with you, that seems reasonable, then you can find another oncologist. But again, right, there are, we have to be respectful for all players involved. And I think that that a physician feels that he's putting a patient at risk by not treating, then they can make that decision.
Okay. Howard, did you have something?
No, go ahead, Jim.
Okay.
I'm trying not to step on each other's toes here.
Okay.
I just want to say that, Howard, if you have that paper that was referred to in the chat room, it might be very helpful for this individual that was just diagnosed.
Okay.
I'm not sure which paper you're talking about.
Someone said in
Is
the
something
chat,
I wrote?
no, someone
Oh,
said in the,
I know the question. I'm just not sure what you're referring to.
yeah, no, I'm sorry. I only briefly looked at the chat room and I thought it said someone said that um, you had that the variables that I had put up for who is eligible for active surveillance weren't the same ones as other people knew, which I'm absolutely in agreement with. These were just examples. And I thought it said that there was some reference to Howard having.
Oh, yeah. Well, I wrote an article. I think what it's referring to is a change in the guidelines from the National Comprehensive Cancer Network
Yeah.
back on September 10th. They sort of lowered the status of active surveillance to being the same as surgery or radiation for men who are low risk. Active surveillance is still the number one choice for very low risk. And the difference has to do with the number of cores and also with the Gleason score. So if that's what you're referring to.
Exactly. And I think for that person that's just newly diagnosed, I don't think it's be very difficult to locate the description of what is what respectable institutions and reports will say is considered the variables that would be considered for active surveillance. So there is just as Howard was suggesting, you know, there's Gleason score, but there's also volume, right? And so if you have, for instance, a 3+4, it does suggest that there's less 4 than 3, but we just got to make sure that there's not too much 4, because 4 can be quite aggressive and its low patients. So there are more specific parameters to determine who's eligible, and that I be well served to learn what those are, and I think they're readily accessible and certainly from this group.
Yeah, I'm going to post something in a minute, although it's really aimed more at a physician audience. So the definitions are a little bit technical, but you know, I think the way you summarized it was just right, Andrew.
Yeah.
So Jim?
Okay. The other mental health issue that surrounds prostate cancer and other cancers is depression. Can you talk a little bit about what the difference is between anxiety and depression?
Yeah. So this is going to be kind of a general statement, but it's helpful. And the idea is that and I don't mean diagnostic, but what I'm suggesting is about 85% of the population has a natural tendency towards anxiety. All right, and 15% has a natural tendency towards depression. And don't hold me to those numbers. I'm trying to give you an example of the fact that, for instance, I'm a psychologist, been working in a hospital forever. I'm anxious. I know that because I have a more kind of inclination towards anxiety than I certainly do depression. I've met people and worked with people with depression, and they have a tendency towards depression. It's got that kind of tendency towards a sense of hopelessness and worthlessness. And so what we want to do is, first of all, define, is this person mainly, you know, part of that population that suffers from kind of a depressive tendency? They've always been felt a little bit like the world was a dark place, and that the world's a very challenging place, and that they feel a little bit isolated in their experience in the world and the like. And that is kind of a depressive state. And when individuals like that are diagnosed, they can they can catastrophize and really go down a dark hole, like they're not going to be around for long. And then and that's that real hopelessness and and worthlessness and guilt and shame, and it's just like it's almost like expected because it's a dark place. It's where there's real sadness. The majority of the depression that we do see, because most of us have more of an anxiety tendency, the majority of the depression we see is anxiety. Is rooted in anxiety. So what happens is that we get so anxious about our diagnosis, and we go global, right? It's not going to be controlled. It's going to metastasize, and then I'm going to die of the disease, and I'm going to lose my future with those people that I love. And when you experience that, then you will slide into a depressed state. That's that kind of anxiety-based depression. And the goal there then is to try to help that individual with his very anxious orientation and worry towards his disease, so that it pulls him back from the depressive side, so that they reestablish a sense of hope. The simple answer to this is, when you're anxious and you have hope, that's anxiety. When you've lost hope, that's where depression comes in.
Okay, thank you. Given the
yeah, Jim, we should check in with Andrew if he has, wants to or is able to continue a little for a few more minutes. Andrew, are you with us, or are you tired and want to call it quits?
No, it's okay. I'm happy to stay on.
Okay. I really only have one additional question, and that is, when a patient is initially seen with a diagnosis of prostate cancer, do you think that there's value at that point to a mental health sort of checkup or evaluation, or are you seeing that coming along as part of a multidisciplinary approach to the disease? And if not, why not?
Absolutely. It's a good question, and I absolutely hope that it continue that there is interest in doing this, and there are hospitals that are starting to do that. In fact, Toronto is in a province of Ontario in Canada, and Cancer Care Ontario is the agency that's responsible for cancer care in all of Ontario, and it made it a mandate that we measure distress in cancer patients. So in order for our hospital to get funding, we have to meet requirements, or our funding gets challenged, right? So it's not a bad way of ensuring that this kind of thing goes on. And so we have, prior to COVID, of course, we had electronic data capture systems where you'd come in, you get an iPad, and away you go. Things are now going web-based because of COVID. But yes, I think it's a phenomenal idea to measure levels of distress on an ongoing basis, not just at the time of diagnosis, but on an ongoing basis, to see patients that might be particularly vulnerable. Another thing to determine is a level of social support, right? That's hugely important, right? And so the more we know as a hospital that this person, how they're doing in terms of their mood, in terms of anxiety and depression and overall well-being and vulnerability, but also how they're doing in terms of, are they supported? Do they have a support system in the community? Because as you guys will know, the person, if you're coupled, probably the person that played the single greatest important role in your acceptance and adjustment to this was your partner, right? Like, or those that really are there for you in the community. So social support is vital. It's funny, I run a private practice with a group, and we have a diagnostic thing, and it follows the regular diagnostic process where we get some background information, and then we talk about and then we do an assessment on their mood and the like. In the hospital, the very same assessment is utilized, except for the very first section is all on social support, just to see, do they have people in their lives that care for them and can be there for them and can support them through this, because the isolation in this experience is the most concerning. And so, yes, I think it would be wonderful. And the reason why people don't is that, or hospitals don't, is that be careful if you ask a question, be prepared to respond to the answer. And so not only, right, do you have to measure whether they're distressed, but but you have to be able to respond to that, which is great in a multidisciplinary clinic, and we can do that. But of course, there's great cost associated with it as well.
I lied. I've got one more question just based on your response. If you identify somebody whose social support network is deficient, what do you do at that point? What do you recommend? Do you recommend support groups? Do you how do you help that person who is isolated with prostate cancer?
That's a great question. And so one is that we make sure that they feel connected to their hospital, right? When they leave, we're not just diagnosing them, giving them a number and splitting. So having a case manager for a patient, for all patients, is very important. But as is true for anything, 10% of the patients take up 70% of the time, right, of the case manager. But that's needed, and that's okay, and that's what the case manager is there for. And then there's also recommendations to, it's not really, it's like Gilda's Club. We have a thing called Wellspring, and it's not just a support group, so to speak. It has exercise programming for patients with cancer. It has nutritional classes and the like. We also have within our hospital, we have a survivorship clinic that's designed to help patients adapt and adjust to changes as they go through this. And then support groups. When I first started, and I'm not kidding you, Jim, 25 years ago, I went and interviewed tons of men and couples going through this, and I thought, okay, there's some levels of distress, and obviously the most economical way of dealing with that is to have a group. But I knew of these gentlemen that would come in from the community and actually be in our hospital on day of diagnosis to talk with patients that are sitting in the waiting room. And I went to talk to them, and they invited me to their group, and that was what group was called Man to Man. Dr. Trachtenberg from Toronto went to the United States and found out about us two and said, hey, we need to have that in Canada, and came back. That's actually the origins of it. And
Oh, yeah, you should know that Jim is the immediate past chairman of us two.
there you go. So it was John Trachtenberg was the head of the prostate center back then. He was smart enough, wink, wink, to hire a psychologist. I'm hired by the surgeons. I work with all GU and all patients, whether it's radiation or medical oncology or whatever. But John Trachtenberg was the one that said, look, we got to take better care of our patients, not just their tumors, right? And anyway, so they started Man to Man, which became Prostate Cancer Support Toronto, and they're fabulous. So yes, try to get as much community support as we can, but ensuring that the patient feels like they have a connection to the hospital is also vital.
That's really all I had. Thank you so
Yeah.
much for your presentation. I'll give you back to Howard.
Yeah, I think I was just going to point out that us two was started here in Chicago 30 years ago by Dr. Jerry Chodak at the University of Chicago. And he was a friend of mine. He was the one who introduced me to the concept of, even just the prostate, because I was only like 30 years old, so I wasn't really thinking about it at the time. And but as a reporter, I reported on Us Two, and Us Two was a response to another organization in Chicago that I had written about, which was Why Me? Breast Cancer Support Group. So it went from Why Me to Us Two, all the way up to Toronto. But listen, you've been a pleasure to have as a speaker. I think everybody appreciated what you had to say, and I hope maybe in the future we can have you back. And meanwhile,
Howard, we as you probably didn't see, it was in the chat. We'd like to invite him to join us for the March 29th session as well.
okay, no, I didn't see that. I don't. Okay,
We're going to. It's the one on health anxiety with Dr. BJ.
Okay, yeah, I know what you're talking about now. I haven't been involved with that, but sure. I mean, once you get pressed into service, Andrew, they never let go.
It might be a good fit. I would enjoy it because, as I said, this talk today was not my usual talk. I did a right turn in the middle because I think it's helpful for people to kind of really kind of, in our discussion previously, Howard, just recognizing anxiety and how it affects us and how do we usually work with it and what are our processes, and we can use problem focused, for things that are in our control, and emotion focused is really focusing on how we're responding to the problem as opposed to the problem itself. And it's a kind of global way of which we handle all problems. It is something in which we use for COVID, for example. And then you can get more and more specific towards health psychology or health anxiety, rather. And there are specifics related to that and treatment paradigms for that. But so I'd be happy to join in and listen to the talk on health anxiety.
No, you're
they
going
want to enlist you to participate.
Okay.
I can connect you with whoever needs to connect with you.
Yeah, let me, I'll just put a quick explanation for the rest of the group. We have noticed through all of our groups, for all of the different conditions, that health anxiety is a huge issue. It doesn't matter whether it's active surveillance, prostate cancer, any other type of prostate cancer, multiple sclerosis, sarcoidosis, any other of the cancers that we serve. Everybody has some sort of anxiety, whether it's scan anxiety, whether it's test anxiety, whether it's just living with the disease. So we asked, BJ Miller is on our advisory board, and we asked if he would be willing to do a session with us on health anxiety for any type of disease. And we asked, since Elliot was one of the main protagonists of anxiety, as some of you may remember, and since he is a performer by nature, we asked him if he would be willing to host this session, and he said he would be delighted to. So we are putting something together for the 29th of Tuesday, the 29th of March. And Dr. Matthew, if you would like to participate in that in some way, shape, or form, we would love to have you.
Absolutely. Be happy to.
Thank you.
Andrew, you're an easy mark.
That's because I can't. It's late at night. I'm too tired. I'm too stressed. I'm just gonna say yes. I'm kidding.
So,
I think I think as much as we've gotten to know you, I think you'd really enjoy it.
That sounds wonderful. Thank you.
We appreciate that.
So I guess, gentlemen, I think we're going to call it a night. A reminder that same time, same station. Next week, we go back to regular support group. So